to Mental Health Matters. I'm Barbara Myers. On today's show, we're going to focus on geriatric mental health, that is, mental health with senior citizens. The elderly population will grow as rapidly as 76 million baby boomers reach age 65 and older between 2010 and 2030. By 2030, older adults will account for 20% of the total population of our country. Nearly 20% of those who are 55 years and older experience mental disorders that are not part of normal aging. Studies report that mental disorders in older adults are underreported. The rate of suicide is highest among older adults compared to any other age group. And the suicide for persons 85 years and older is the highest of all, twice the overall national average. Clearly, this is something that our society needs to come to terms with now. I'm joined by two guests who have experienced this issue in their lives. Arthur Strosberg is a man who developed depression when he was a senior citizen. He was greatly helped by the Older Adult Transition Services program at El Camino Hospital in San Jose. We're looking forward to hearing your story. Welcome, Arthur.
Thank you, Barbara. It's a pleasure to be here.
Dr. Akbar Gilani is a board-certified psychiatrist who works at Eden Hospital in Castro Valley. His specialty is geriatric psychiatry. Welcome, Dr. Gilani.
Thank you for the invitation.
Arthur, you can start by telling us your story. Did you have any hint of depression before you became a senior citizen?
It's hard to say whether or not I did, Barbara. However, as I was growing up, I commenced to develop a complex where I thought that I wasn't good enough. And that emanated from interactions with my father, particularly around schoolwork, when I used to bring home papers that were graded, for example, like 98. And the response I got was, couldn't you do better? And that was said with a straight face. So I was really hurt by that.
What did you do in your life before you became a senior citizen?
Before I became a senior citizen, I was a PhD trained pharmacologist, and I was the head of a couple of departments in a major pharmaceutical company, and finished up working in that company as the head of research administration and policies for their research organization.
After you retired, did you then start to have difficulties with depression?
Well, actually, I had some minor to moderate depressive episodes even before I turned 55. However, these were readily taken care of by taking drugs such as Paxil or Effexor as an example, or as examples. I actually have suffered from depression on and off for about half of my life. And approximately 10 years ago, I had a bout of serious depression.
I understand that you were better for 10 years and then had a relapse. What were the factors that led to your relapse?
Well, regarding my relapse, which occurred this past January, it actually came on very suddenly, and I felt like I was going over a precipice. And I'm not exactly sure what led to this depression. One of the things that may have led to it was that one of the antidepressant drugs that I was on was discontinued approximately 6 months before because I had a sudden increase in my liver function tests. And upon cessation of this drug, my liver function tests returned to normal. So I was off of that drug for over 6 months. At the same time, unfortunately, my psychiatrist retired, and I was left out in the cold with no one to go to.
Now, how was your personal life affected by depression?
Well, my personal life was affected by the fact that I did not wish to socialize with anyone. I did not respond to my emails. I walked around my home in circles. And needless to say, this was quite disturbing to my wife. And as you can appreciate, it's very difficult to live with a depressed person.
Right. And then how did you go about receiving help? Did your wife help you with that, or? Well,
actually, the depression continued to get worse. And then it was my wife and two of our very good friends that took me to El Camino Hospital, where I was admitted into the psychiatric unit. In fact, I spent almost the entire month of February in the unit, at which time I was evaluated and released into the OATS program at the hospital. El Camino Hospital also has a partial hospitalization program for 18 to 55-year-olds. However, older adults have different issues, and therefore they began the OATS program.
Okay. Okay, well, thank you. We'll talk a little bit more about it later. I wanted to ask Dr. Gilani, can you explain to us what a geriatric psychiatrist is?
Barbara, a geriatric psychiatrist is a psychiatrist after 4 years of internship in psychiatry, then they added 1 year of fellowship. And most of this fellowship curriculum relates to geriatrics and older adults, and it also includes treatment and evaluation of dementias and other depressive mental health problems that could occur.
What kind of mental disorders are typically seen in the older adult population?
Typical major depressive disorder is not as common as depressive symptomatology that is exhibited in older adults. That's very common to see. And then we have cognitive problems, anxiety problems. Also there's late onset schizophrenia, which is not as common. And these are and substance abuse. These are the problems that we can anticipate in older life.
So how do you differentiate between these kind of mental disorders from dementia?
The most important factor in evaluating cognitive problems or memory loss, difficulty in kind of doing our daily routine that we were doing before, it's important to rule out the reversible causes of dementia. There are many times there are malnutrition, there are other medical causes that can mimic dementia. In fact, depression itself can present as dementia. And while we treat these disorders, the cognitive problems would reduce or go away. In dementia, which is dementia of Alzheimer's type, is the most common form of dementia. It's a progressive illness. So there will be problems in speech, language, and motor functions. And these problems can go on in a severe manner that the patient would be limited in doing their daily tasks.
So you screen the people that you're working with to see, whether they fall into one category or another.
Correct. Yeah. We have certain lab work that we do and certain clinical tests we also do to evaluate these problems.
When you work as a geriatric psychiatrist, do you typically work with a single client, or are you called in as a consultation? How does that go?
Commonly what would happen is that as elderly would suffer from depression, and they would seek treatment from their primary care practitioner. They would put them on medications. Many times when these medications are not effective, or primary care physician is not sure what antidepressant to put the patient on, or there are multiple other medical problems, drug-to-drug interactions, that's when a primary care physician would consult with a geriatric psychiatrist, and he would be brought in.
At what age do these kinds of problems typically occur in geriatric psychiatry?
Depressive symptomatologist Arthur's story is very typical and common, that he has suffered from bouts of depression that have become more severe at a later time in life. It could be different for different people. Many times as we are growing old, there's a loss of function. We've lost friends, there's family illnesses, there's death of friends. And these isolation can lead to more depression. And so this is very important that we look into these when the onset occurs and get promptly treated.
Right.
If we come at the right time and get treated early, then certainly we can reduce the greatest risk of depression, which is suicidal thoughts and suicidal attempts.
Because you mentioned some of the factors that cropped up, having a spouse dying or having grief or delayed grief or something for a family person, health problems that would happen at more an older age and perhaps be viewed in a hopeless way by the person. Maybe financial problems because they aren't working, or a loss of their loss of role in society, or, thinking they don't fit in because they aren't in a job anymore. So, yeah.
That is correct.
Yeah.
I mean,
Okay.
many times depression would occur because patients have pain. They have never experienced depression, but because of pain issues, now they've started experiencing depression.
Yeah. How did you get interested in being a geriatric psychiatrist?
I studied as an intern in internal medicine, and then later on, I had some interest in my rotation in psychiatry, developed an interest, and then as life goes on, I had some of my family members that suffered from depression, and then later on I got into residency training. And I was fortunate enough to go to Stanford to do a one-year fellowship in geriatric psychiatry, and now I've been working at Eden Medical Center for about the last 11 years.
Arthur, I wanted to ask you a little bit more about the OATS program. OATS stands for Older Adult Transition Services. It's at El Camino Hospital. I guess you went into that program because you had been an inpatient in El Camino Hospital, and then when you were discharged, and because of your age, they put you into that program.
That's correct, Barbara.
Okay.
And as I mentioned earlier, the OATS program was developed because older adults have different issues than younger adults. For example, their drug treatment has to be very delicately handled. Another thing that I want you to keep in mind is that Medicare allows for longer treatment than private insurance does. And so this is another aid, if you will, in the OATS program. And it's been found that older adults generally recover within 3 months and then return to complete functionality in 6 months. And because of that, El Camino has developed care groups that are called healing circles that start to cover this restorative period.
So this is after you've graduated from the OATS program, they have this long-term care program.
That's correct.
Okay.
And as a result of the longer treatment in the OATS program, a community develops amongst the patients such that recovering patients really give hope and help to new patients. And I can tell you, for me, this was extraordinarily valuable. And so the therapists, as well as my collegial patients, really played a great role in my recovery. The OATS program meets 4 days a week for up to 5 hours a day. It is staffed by a psychiatrist medical director, by a geriatric clinical nurse, and by nurses, by family and marriage therapists, as well as occupational therapists. In addition to that, each patient is assigned a caseworker who is one of the professional staff who actually provides treatment planning, family intervention and education, and individual counseling.
So they talk to the family as well as to the client.
When necessary.
Right. So what's a typical day like there when you went to the program? What was
Well, the program is centered around cognitive behavioral therapy, and a typical day consisted of cognitive behavioral therapy sessions. In cognitive behavioral therapy, one learns about the role an event plays in the production of automatic thoughts, which in the case of depressed people generally tend to be negative or distorted. And one learns to develop counteracting alternative automatic thoughts, which in fact lead to better feelings.
So can you give an example of a thought like that?
Yes. For example, one may be driving their car and suddenly realize that they're about to run out of gas, and then the automatic thought may be, I'm a real jerk because I didn't fill up my tank when I should have. I'm a loser. And the feeling would probably be one of fear, fear that you're running out of gas, and anger at yourself. And then the alternative thought or thoughts may be, well, I may make it to the gas station, and if I should run out of gas, I can call AAA, and they will come and provide me some gas, and I can continue on.
So you're substituting positive thoughts for the negative thoughts.
Right.
Yeah.
And then you feel much better.
Yeah, okay.
And that's the aim of cognitive behavioral therapy, is to decrease these negative thoughts so that one does not continue to go downward. And the OATS program includes identifying and regulating your feelings. It provides communication skills. It reviews your life, especially what happened in your childhood, and the roles of family and friends. It provides psychoeducation, that is a diagnosis and symptoms of depression, anxiety, and bipolar disease. It also includes the value of play, leisure, and recreation. And the effects of change, transitions, and loss, as Dr. Gilani had mentioned, which deals with the handling of grief.
That sounds pretty comprehensive.
It definitely is, and in essence, it covers the difficult decisions that are encountered in older adults, in older adult life. And most importantly, it provides you with a positive psychology that promotes health and wellness in the older adult. So in short, the OATS program provides one with all of the tools that are necessary to live a happy, healthy, and positive life.
I understand that you found your life transformed because of the experiences that you had in the OATS program. Can you tell us a little bit about that and what it was that led you to that transformation?
Yes, I can. As I indicated earlier, I felt that I wasn't good enough. And I have carried that complex, if you will, around until the OATS program. And because I felt I wasn't good enough, I never took pride in anything I had done. And I have done a lot of things, and fortunately I did most of them very well. But again, never took pride in them. And in the OATS program, through positive affirmation statements, I finally appreciated that I am a worthwhile human being, not because of any accomplishments I've made, but because I'm me, a unique human being, just like you and Dr. Gilani.
Isn't that the thing that really turns around when you get that, you know?
Absolutely. And I cannot tell you what a weight that is to have lifted off of your shoulders. And also, because of not feeling that I was good enough, I strove for the unattainable perfection. And so here, again, with the help of OATS, I've lost my perfectionistic tendencies, if you will.
Well, congratulations. I know that because in my own life I went through some of that too.
And I can honestly say that I live my life much more easily today than I ever had, and I look forward to every day. And to me, oats really has been the greatest thing that has happened in my life.
Now, do you continue to have a psychiatrist or a mental health worker? You're part of this aftercare program, but you still see a mental health care.
During the oats program, I did not have a geriatric psychiatrist. I did, during the program, go visit a geriatric psychiatrist once to get the psychiatrist's view on the drug treatment regimen I was on. And she was very, very helpful in recommending a change in a couple of drugs, which the medical director psychiatrist in the program did in fact change. However, now I have come or gotten hold of a geriatric psychiatrist whom I am seeing, and I call her my geriatric psychiatrist.
Dr. Gilani, can you tell us what kind of therapies that you use with geriatric patients and how they might be different from the other patients?
Very typical from Arthur's experience, once again, as what kind of therapies that were utilized in the outpatient program: reminiscent therapy, cognitive behavior therapy, family therapy, interpersonal therapies. All these modalities are utilized. It depends when you're talking to a patient, what are the needs of the patient, you address them. And once you answer those needs, it makes patient feel better, it makes their communication better with their family members, and it helps everyone.
How do people find a geriatric psychiatrist? Is it just Google it or something? Or
probably you can Google a geriatric psychiatrist.
Okay.
What I would recommend is not easy to find a geriatric psychiatrist because there are not enough geriatric psychiatrists to fill the need. So, and our community psychiatrists who have experience with geriatrics are very well able to fulfill the job of taking care of our patients. And if there's a further need for consultation, then they would consult with their colleagues.
I guess I wanted to ask both of you, what can family members and friends do to help a loved one who has developed a mental disorder as an older person?
Well, I think that family members need to be as supportive as they can, as hard as it may be. I think that people with depression need to realize that this is a disease that affects not only from here to here, but your whole body, and it is treatable. One needs to avail themselves of that treatment. And when you're 65 and over, one should see a geriatric psychiatrist, such as Dr. Gilani.
What I would emphasize is it's not uncommon for the caregivers to experience depression. And depressive symptomatology is more common in caregivers who are caring for people or family members who have dementias. So more than 40% of them would experience depression. So it's integral because they are the caregivers, they are the providers, that they take care of themselves.
Now I'm going to talk to you in the viewing audience. Do you know someone who is a senior citizen who's struggling with symptoms of a mental disorder? And maybe it's someone in your family or maybe it's you. If so, I'd like you to think about what you've learned from this program. The main messages are that mental health problems can come in older age, even if it hasn't come in a younger age. And these problems can usually be treated successfully, sometimes with a whole new lease on life, like Arthur had, and a geriatric psychiatrist can help. So I want you to think about this and then decide what kind of action you're going to take with that special person you're thinking about. I'd like to leave you with some resources. The American Association for Geriatric Psychiatry deals with education, research, and advocacy for these kinds of issues, and their website is on your screen. Next, the Geriatric Mental Health Foundation is a foundation that raises awareness, promotes healthy aging, and increases access to people who are in the geriatric community. I'll give you a reference to the Older Adults Transition Services program that Arthur participating in El Camino Hospital in Mountain View that has psychiatric treatment and all the things that he talked about with cognitive behavioral therapy. And to complete the show, I'd like to leave you with the words of the Reverend Wayne Arneson. Take courage, friends. The way is often hard, the path is never clear, and the stakes are very high. Take courage, for deep down, there is another truth. You are not alone. Thank you for watching. We'll see you next time.